We are a publicly traded company, so I urge you to go to our website and look at our SEC documents to ensure that you understand all the risks and benefits of our company. pSvida is a company that's involved in building value through preventing blindness. And you've seen many companies up here today who are involved in either preventing or even curing blindness. And I just want us all to remember what an incredible mission that is. And also to say that we continue to price our products to give patient access while ensuring we give a return to our shareholders. So it's both that we need to keep in mind. We have a very robust pipeline. I'm going to go through that as I go through my slides today. Our technology, as you can see, is quite innovative. We can go up to 3 years, even down to several months, depending on the compound and what is desired. It is proprietary. We have broadly applicable patents, and we're quite pleased with what we've been able to do with our Durasert technology. Of note is our zero-order release pharmacokinetics. You can see here, this is at 30 days, and then all the way out to 180 days. As I said, we can go out to 3 years, but you get that very, very nice, steady, consistent release mechanism. Our main opportunity coming up and pivotal catalyst for the company is we're getting ready to file for our posterior segment uveitis indication in late December, early January of this year, and I'll go into the data on our 2 pivotal phase 3 trials. Our milestones achieved, we've had a very busy year, quite pleased that we reported out positive results on our 2nd phase 3 study. We've also announced that we've entered into 2 collaboration agreements with several companies in glaucoma. We expect as we go into 2018, we'll announce additional collaboration agreements. As I've mentioned, we expect to file our NDA. And we've made very good progress on our bioerodible platform for sustained release up to 6 months. These are our 2 pivotal phase 3 trials. Again, I'll go into more of the data, but we have 2 of those, both highly statistically significant at greater than less than p.001 for both studies. We also had an inserter study for ease of administration, which showed positive usability. Diving into the data some, you can see here very nice results at 6 months. This is prevention of recurrence of posterior segment uveitis. Again, highly positive statistical achievement. And of note is that as we go out in time, you can see we get a nice durability of response, and we even further separate from sham as we go out in time. On our 2nd study, again, we had very nice results, another p-value less than 0.001. You can see sham performed a little bit better in this study than the first study. Primarily, that's attributable to the high amount of rescue medications that were allowed in both studies. And taking a look at our Kaplan-Meier curves, on the top is our intent to treat, on the bottom is our per protocol. You can see the curves separate beautifully and continue out as time goes on. And again, as Emmett mentioned in the early morning presentation, our hazard ratios are very nice for both curves. And this is looking at, I mentioned this, the amount of systemic and intraperiocular steroids that were given as rescue medications. You can see for the active arm, we had about 19% given for systemic and 7% for intraperiocular. But however, look at sham. You had 40% of systemic medications were given, and 62% of the sham arm were given intraperiocular. And yet, nevertheless, you still saw that very, very nice separation occurring on the Kaplan-Meier curves. Okay, next slide. We don't seem to be moving here. Now, turning to safety. We all know steroids cause elevation of IOP, and yes, we did see it, but again, relatively modest. The mean IOP elevation for one of our studies was 1.1 millimeters versus sham, and on the 2nd study, 1.4 millimeters versus sham. And looking at cataracts, it is rather interesting. We had opposite effects. These are numerical differences, not statistically significant. You can see in both studies, we did see increases in cataract. However, in one of them, sham performed worse, showed more cataracts than the active arm. In the other study, the active arm showed more cataract formation than the sham arm. And again, when we looked at the data, it's primarily attributable to the amount of rescue medications given in the sham arm. Now, as we dug into the data deeper, we split out on macular edema at baseline, and these are results at 6 and 12 months. You can see that a lot of the patients, over 70%, had macular edema, no surprise, and yet at 6 months and then out to 12 months, you showed a nice drop, and particularly a little more, obviously, with the active arm than with sham, so we were pleased with these results. And if you look at our central foveal thickness, again, you see a very quick drop-off with the active arm. You ultimately do get to the same result with the sham, but it takes much longer. If you look at vitreous haze at baseline, you can see results at 6 months. That again, those patients who had absent or trace vitreous haze, again, you saw some slight improvement, not a lot, and no degradation. However, when you look at those patients who did have vitreous haze at baseline, you saw a significant improvement in the active treated arm versus sham, and again, no reduction in or denigration in vitreous haze, and a slight denigration with sham. And moving on to macular edema at baseline, again, you can see those who had visual acuity impairment due to the macular edema, you saw some slight improvement, but of note is those who did have visual acuity impairment with macular edema, you saw some significant improvement in the active arm. Now, moving on to our pipeline, you can see here, this is our short-acting product, which we're quite pleased with the results. We're getting very, very nice release mechanism layered right on top of the 3-year. We expect that we'll be coming out this at about a 9 months release. So we expect to file this, again, for a uveitis indication, again, probably about a 9-month release product. I mentioned our collaborations in glaucoma. We all know glaucoma is a very, very serious condition, widely impacting a large number, 2.7 million people in the US. We're pleased, one of the announcements we've not disclosed who the partner is. The other one we have disclosed, it's NICOX, so we'll be taking their nitric oxide donating molecules into our bioerodible delivery. And onto the bioerodible, you can see here we're quite, again, pleased with the results that we've had with our bioerodible. We're getting very, very nice release profiles. This is actually with steroid, and then in our TKI program, we're now seeing some nice results in preclinical in the release profile with a particular TKI program, again on our bioerodible device. So in summary, we're quite pleased with our results. I want to thank my team. Many of them are here. They're just doing a terrific job. It's all about a combination, I agree, of assets, but if you don't have the right people, you can't make the progress that you need. So thank you, team, for this great results this year. As I've mentioned, we're getting ready to file our NDA. We've got additional collaboration agreements that we expect to announce, and several already announced, and great progress on our bioerodible. So thank you very much.